Welcome to Nurse to Health, where we bring you behind the scenes and to the front lines of healthcare. Brought to you from the beautiful campus of Hofstra University in conjunction with the Hofstra Northwell School of Nursing and Physician Assistant Studies, and with the ever-present support of John Mullen here in studio with me, radio station manager and studio engineer. For today's episode, I'm joined here today with my co-host, Kareem Nagdala. Hello, Kareem.
Hey, Bob. What's up?
And on our last podcast, you heard a fascinating conversation with Petra Volpe, the acclaimed Swiss director behind the powerful new film, Late Shift. Late Shift had its world premiere at the Berlin Film Festival in 2025. It's an incredible film that follows a dedicated nurse navigating the chaos of an understaffed hospital during a high-stakes shift. It's a really gripping documentary-style drama that shines a light on the intense pressures that nurses face daily. And I mean, it's a foreign film, but it's pretty much a universal theme. Today, we're going to use Late Shift as a springboard to explore how art mirrors reality, and especially in the wake of the historic New York City nurses strike that just recently wrapped up. So in addition to my co-host, Dr. Nagdala, I'm joined today by Jess Keenan and Aaron Mandel, two graduate students pursuing CRNA and family, which is a nurse anesthesia degree, and family nurse practitioner degrees in a very special and unique program that we have here at Hofstra. So welcome, Aaron, and welcome, Jess.
Thanks for having us.
Thank you for having us.
You're very welcome. So why don't we start out with each of you telling us a little bit about yourselves, and then we'll sort of dive into the meaty part of the podcast.
Ladies first.
My name is Jess. I'm originally from California, from the LA area. I'm a current first-year CRNA student here at Hofstra. My work history, I was a CTICU nurse for adults for 3 years out of state, and then for the last 6 months before I started the program, I worked in peds cardiac surgery and also adult cardiac surgery here in New York.
Okay, welcome. And I just want to tell our listening audience, we pretty much hijacked or kidnapped Jess. Really, so just as of 20 minutes ago, she had no idea she was going to be here. So really,
I can confirm I was roped in, but I could not say no.
A very special welcome. And you know, we'll get back to it. We're going to very much appreciate your perspective because you've worked out of state. And we mentioned we're going to talk about the New York City strike involved 3 different hospitals, but I mean this is a universal issue. And Aaron.
Yeah, hi. I worked in MICU for 4.5 years or so.
What's MICU?
Oh, sorry, in the medical ICU in Connecticut. I'm from Connecticut.
Like a foreign country.
Yeah, basically. Yeah, I feel like I'm a foreigner on Long Island, not in Long Island. Slowly acclimating, and then I did 6 months in a float ICU position out in Colorado before starting this program. First year with Jess here. Looking forward to talking to you guys about the film and the nursing strike and everything else that we're going to talk about.
So we're going to get right to the film because I know you just watched that. For those of our listening audience who are not familiar with it, what's a float? Because we're going to be talking about working conditions for nurses and all. What's a float mean?
A float is kind of like the safety net kind of for staffing that we have in the hospital. They don't have a home base. Their job is to backfill call-outs if there's an increase in acuity in a unit and we need to tighten the ratios up. The float pool is the ones that are kind of like a jack of all trades. So they can kind of go and fill in any given unit, and that's their role. So they come to work every day not knowing where they're going to be going, and they get to work and find out, hey, I'm going here today to this unit, and then they hopefully avoid crisis or staffing crisis, I mean.
The reason I wanted to emphasize that is going to be a big part of our discussion because during the strike, the patients don't suddenly get better. They need to be taken care of. So something has to happen to fill in the roles of the striking nurses, and travel nurses or float nurses become a big part of this story, correct?
Absolutely, yeah.
Yeah, so we'll come back to that. So let's just dive right into the film. You watched it. Tell us your thoughts about the film.
Yeah, I mean, besides the fact that I don't speak German, luckily there was some subtitles. But even with the language barrier, it was still, you could still kind of get the sense for the film. Everyone knows Grey's Anatomy, all these shows. There's lots of drama, and high stakes and everyone's always dying, and the focus is on kind of that like high adrenaline situation. This was super cool, especially being a nurse myself. It was really showed like what it actually is like to be a nurse. It shows her running back and forth from room to room, answering call bells, getting pain medications, drawing up medications, having to deal with transport issues, a patient calling in one room and having to bring your other patient a CAT scan. So it was just very cool to see someone portray the actual like day-to-day nursing.
Yeah.
I don't think I've ever seen anything like that before. That was super cool. And like you were saying too, the actress that was playing, I forgot what her name was. Floria, yeah. You would think she was a nurse. Like, she did such a good job acting, and all the mannerisms and her body language and her responses. It was all very, I don't know how she prepared for the role, but it was definitely
I mean,
well
the
done.
director, Petra Volpe, told me, she really immersed herself and studied it. I mean, I had mentioned to you, I watched it with my wife. I'd watched the film a couple of times. And my wife said, wow, this is a fantastic nurse. And she's not a nurse. She's an actress. No knock on The Pit or Grey's Anatomy or any of them. But this was unique in the fact that you were like a fly on the wall. You were like the camera. You were attached as a viewer to the camera, just focused on her. So there was no distraction in terms of storyline or other character. It was really immersed in her world. And you got to see she never stopped moving. Right? I mean, she changes in the locker room in the morning, or not in the morning, it's in the afternoon, early evening shift. She changes, she never stops moving. So there's like physical, emotional, mental, psychological demands that are really nonstop. I'm not a nurse, but you're saying it struck home, right?
Yeah, absolutely. I mean, I think what you just said about her not sitting down, that was I think not that every day is like that, but like any job, there's some days that are easier than others, and however you want to define easy, but there's definitely, we've all had those days where you get to work and you don't stop moving. Like, for instance, she walks onto the shift, and the first thing that happens is a patient's being wheeled in, and her colleague's like, hey, I got one for you. And then she says to her late shift colleague, like, oh, the piece, it was like the piece end, or there's never even peace at the start of the shift, or something, where it's like from the second she walks into the unit, it's already starting, and then it goes all the way till she clocks out. Like, it's a nonstop thing, which I think was portrayed pretty well.
Just based on that description, how do you react to that? Does that ring true? Does that sort of, been your experience yourself?
Just in terms of day-to-day as a nurse?
Yeah, how it relates to you, your experience as a nurse. How long have you been a nurse?
I was a nurse. Well, I guess I still am a nurse.
Still are, yeah.
For 3.5 years bedside. I definitely agree with Aaron. You definitely get those days where you come into work and before you can even clock in, you're getting waved down because your patient is X, Y, and Z, right? Whether you have to go to the CT scanner, you have to admit them from the operating room before you put your stuff down, or even, something else is going on with them on the unit. You have those shifts where, you have a bunch of different patients and you're going back and forth, and depending on the acuity or, what's going on that day, you definitely have those days where you are not sitting down, whether or not like you forfeit your lunch breaks. Sometimes it's up to you, but there are definitely shifts where you don't get lunch, you don't sit down, and I've left with not going to the bathroom. On the flip side, there are also shifts where, it's not always like that. It really is a toss up. It definitely comes down to like the unit and the floor. Yeah, it's definitely unpredictable, but it's definitely something that isn't rare, I'd say.
I want to get to Kareem in a second, but what struck me about it was, so I'm a surgeon, and there's always been sort of the common wisdom, let's say, was that doctors are giving the orders and the nurses are carrying out the orders. Doctors are in charge of the big decisions. What struck me about that film was, and I've been doing healthcare for a long time, but sometimes you just need to focus on something. What struck me was how much decision making the nurses had to do. I mean, nonstop decision making, different types of decisions, lots of nonstop decision making. Do you feel that?
Yeah, absolutely. I mean, you have two different situations. Well, you have multiple different situations of having to make decisions. The two that come to my mind are, you have that one very sick patient, you need to give them X, Y, and Z. You have to give them 3 different medications. The orders are coming in and you have to put them up, right? And then that's when we like to say like team nursing comes into play, because you're one person. You can't hang 3 medications at one time and then drop an OG tube and do all these things. So having good coworkers comes into play for that. And then other types of decisions, say you have 2 patients and you just got report on both of your patients, and then they both have 12 medications due, with some being sensitive. If it's a transplant patient, that has to be given at the same time every day, but then your other patient's in pain, but this patient is a little bit more sick and you're more worried about that patient. So making the decision of who to see, prioritizing, deciding what medications to give first, and kind of just starting your day. That's on a day where you have, two very busy patients, but then also that's without any other interruptions coming in that you can't plan for.
There's always interruptions, right? You're always being pulled in different directions. You're always multitasking. I mean, that never stops. Kareem.
So I have a bit of a different perspective. Because you guys said you worked in ICU, correct? Mm-hmm. Yeah, me as a nurse, I didn't work in ICU. I worked ICU as an NP. As a nurse, I did general telemetry. So I had cardiac surgery. I actually, looking back at my nursing career, I worked at the mothership Manhasset Hospital, North Shore University Hospital. It was always crazy, always busy, because that was like a transfer center back in the day. I mean, you would get patients from every single hospital on Long Island. They would transfer them there. And the unit that I worked on, the acuity just got worse and worse as years went on. They had all these programs that had opened up. When I left, that's when they just opened up the heart transplant. So that was like the pinnacle of the acuity that we were getting. And the ratios weren't great. The ratios, you had 6 patients some day, 8 patients the other. If it was a blizzard and there was nobody there, who knows what the ratio would have been. Obviously, I haven't been at the bedside as a nurse for 7 years now. I've been an NP for 7 years. But when I think back to my nursing career, it was exactly what you guys are explaining to me. It's like there's never a dull moment during the shift. Even when the shift should theoretically on paper be quiet, nice, easygoing, there's always something that happens. It's a very demanding job physically, but also emotionally, because you see people that you've been taking care of for a week and then the next second they're gone. It brings back a lot of memories for me, for sure.
Good memories, or?
I mean, good memories in the sense that I had a lot of experience with the type of the patient. It made me who I am today, for sure. I guess in terms of the patients, obviously, I love my patients. They were fantastic. Thinking about the things that people are fighting for today with the whole nursing strike, it brought back some memories to me that made me say, hey, you know what? I understand where they're coming from with that. I really do. These guys, they work really hard.
Yeah, which is why we're doing, a lot of the reason we're doing this show. So let's dive into that. Let's tie this to real events. So let's talk about the strike. So 41 or so days on the picket line in freezing winter, January, February, 15,000 or some odd nurses from 3 major hospitals, right? Mm-hmm. Montefiore, NewYork-Presbyterian, and what was the one? Mount Sinai, right?
So the thing is, what I heard, because I don't work for that health system, and I don't really know those nurses firsthand, but from what I heard, they were really, the crux of their issue was the nursing ratios. And I find it interesting that that you're coming from California, because as I heard, again, I haven't worked in California, but they have like legislation there that would limit the amount of patient ratios.
So I actually never worked as a nurse in California, but I have a friend who works in Northern California and a friend that works in Southern California. I think the one in Northern California works at a unionized hospital. The one in Southern California does not. Even in the hospital that is not unionized, I know that they have a resource nurse every shift. Mm-hmm. She works in an ICU. Different resources that would help a staffing ratio. I actually think at that particular unit, they might be overstaffed because they get put on call a lot. And I don't hear any complaints about the ratios up in Northern California, but when I'm looking at what New York City is fighting for a fair contract in terms of pay, I know that they are behind Northern California.
Interesting.
I just found this out recently because I researched the topic. New York has had legislation on the books since 2021. It just hasn't been enforced all that well, or inconsistently, let's say. Department of Health, they probably have their own staffing issues to deal with, so it just doesn't get enforced. And there's some pending legislation, both nationally and in New York, that's sitting around up in Albany and in Washington. But yeah, California kind of led the way with that. I guess, I'm not really sure. I mean, from what you're saying, maybe they enforce things a little better. But they have their issues also.
Everyone has their issues.
Everybody has their issues. But let's just talk about staffing ratios for a second. So, Jess, you and I just discussed it kind of on the way over here. And we mentioned it before, Aaron. You had mentioned it. That's a very variable thing, like a lot of this. a lot of the problem tends to be focused on intensive care units and the emergency department, but it applies to pediatrics, the floor.
So I've only worked in ICU, but I guess from like floating experience, I'm sure, Aaron, you floated as a nurse as well.
When I was float pool, we were ICU, but we also had to cover step down and the floor. And I'll tell you, like, staffing in the ICU, short staffing sucks, but on the floor, I think it sucks even more. When you already are stretched to a ratio of 6 patients to 1 nurse, and then someone calls out, and then now you're taking 8 patients. It's incredible that, the nurses can get through a full shift and get all their tasks done.
The film really puts, sort of a exclamation point on this, because unless you see what's going on or you've been there, it's hard to just describe. It's just like people are like, yeah, right. But when you see it,
oh yeah, definitely. And also, I'd be curious to know. I didn't listen to the episode last with the director, but how she got so much insight into what it's like to be a nurse. Most people that don't have the experience being a nurse or even being in a hospital working, like, your experience is being a patient or being a family member. So it's very like myopic, kind of like one. You're seeing just the stuff that's right in front of you in that room. And obviously, why would you be focusing on anything else? I had no idea what being a nurse was like before I was a nurse, and how much like stuff there is behind the curtain. Like, most people have no idea about, just like the logistical things, the phone calls, tracking things down, making sure you have like enough syringes to drop medications, all these little things. And that, to me, is what was so impressive about the movie. And not to go back to that, I know we're kind of shifting gears forward. They did a great job of portraying all those different things. So then you go back to staffing, to come back now. When you're short-staffed, all these problems still exist. You're just stretched even more thin. And I think that's one of the biggest issues. If you talk to any nurse, the East Coast, the West Coast, and everywhere in between, I think staffing ratios is going to be one of the hot topics for everyone.
But the interesting thing is the way that it's portrayed in the media is that the staffing issue it's like a worker's gripe. They just want an easier day on the job. But the reality is, it's not what it's about. It's about the patient care, right? Because the patient care suffers when the ratio.
Oh yeah, and look, I just looked into this. I mean, I knew about it, but not enough. There's many studies out there confirming morbidity and mortality relative to staffing ratios globally. It's a real thing. It's not make-believe. Now, to be fair, give equal time to the other side, so the administration, they'll claim, there's a money issue in the sense that, and this is not across the board, but a lot of institutions do run with very tight margins, if any margins at all.
Yep.
So listen, the money's got to come from somewhere, so there is that. But there's no doubt that staffing makes a difference. I mean, if nurses are overwhelmed, like Jess, you mentioned, you can't be doing 10 things at once, and you can't be at 2 places at once. And not to mention, we already have, just in healthcare in general, understaffing, and that goes for doctors as well.
Across the board.
Nurses burn out. We're human beings. You can only take so much, and then you're like, I'm out of here. That's not going to help. It's not going to help.
The thing is, it's frustrating when you can't deliver the type of care you're capable of delivering, and then you physically just can't because of all these things that you were just saying, Aaron. I mean, imagine you have all these things going on, and then you have to pass meds. You have family members waiting on the phone. The family member's upset. I mean, we've all been in that situation. You want some information on a family member, and then a rapid response happens. That just upended your entire day.
Mm-hmm.
I think what you just said about, like, it makes it hard to do the job that you want it to do. Like, say you want to get your patient out of bed. It becomes a very triage thing where you can't do all the extra things that go above and beyond that. Like, that every patient deserves and that you want to be doing. But you kind of have to focus on the immediate life or death, or not even life or death, but just the things that need to get done versus the things that you want to get done. And sometimes those things, like, maybe you meant to order your patient like a hot coffee, and then you forget about it for an hour because you got sidetracked. And it's these little things where it's like, you feel horrible because this person's, they're sitting in a room alone and you've got to do one little thing for them. But I think those little things is what all the staffing issues are about, because I don't know if there's data to support, looking into this, you'd have more time to do those little things.
The human things.
That which one are good for the patient, but two, for us, that's kind of what we, that's why we got into healthcare, to do these things, to not just go around and pass out pills and to do this, but to actually connect with people, to help them heal, to connect with their family, and it all takes time. And I think one of the biggest things we want as nurses is just more time, and it's tough because there's all this charting to do and all this formality of things you have to do and do this and do that and these protocols you have to follow. And it really takes away time that you could be spending with a patient to do more.
But let me ask you, because the staffing ratio goes one of two ways. It's either it's the number of patients to the number of nurses, or it's based on acuity. And I think that recently a lot of the health systems at least have gone towards acuity-based staffing. But I feel like now we're at that breaking point where the acuity thing, we've already exhausted that, right? We're already doing the acuity-based staffing, and now it's kind of like, okay, so now after we've done that acuity-based staffing and we're not getting the results that we wanted, now what's the next step?
People talk about a mandated ratios. So some people say, hey, we want to have ratios, but it's got to be more flexible. We don't want to have 2-to-1. We don't want to have 4-to-1. So that flexibility needs to happen. That sounds reasonable. The discussion has to happen, right? I mean, that's the problem. And then just to Aaron, people use the term for what you're describing as moral distress. And, when you go in, if you're a healthcare worker, you go in this for all the right reasons because you want to basically help people, right? I mean, that's what you want to do. And not just physically and not just medically, but emotionally. And you can't do that. There's a certain moral distress, not to mention, mistakes happen, right? I mean, it's just human.
Totally. And I think that the mistakes get exacerbated when you have these acuity issues, right? For example, let's say we said the ratio, I used to work telemetry. Let's say that they mandated that the ratio is going to be 1-to-6. No problem. But what if those 6 patients, each of them is taking 20 meds? Just using a round number. Every single medication you have to verify, the dose, is there a drug? Like, the nurse is supposed to be the last line of defense. And I think that gets lost in a lot of these conversations because let's say the doctor orders or the nurse practitioner orders the medication. Pharmacy verifies it, but then it gets to the nurse to administer it. The expectation is that you're going to be that fail-safe to make sure that the patient doesn't get harmed. It's hard to do that when the acuity is too high.
Right.
I've never worked in a mandated hospital. As much as we all want, like, the ideal staffing ratio, you always want, like, an ICU 2-to-1 if you have some sort of device, meaning some sort of, like, continuous dialysis or a heart-lung machine. For those listeners that aren't as familiar with some of the stuff, those usually are 1-to-1, so it means, like, one nurse to one patient.
ECMO.
ECMO.
This is cardiac
a bunch of
support.
It happens a lot in the cardiac ICU and the cardiothoracic ICU. And step downs usually 3-to-1, the floor, 5 to 6-to-1, whatever it is. We all want that. But then the other side is, like, we have to be realistic as, that's not a perfect world. How do we obtain that where, if we start mandating you to come in on your off days, that's not going to increase staff satisfaction. No one wants that. So it's like, there has to be some give and take. And I've never really worked too much in the the admin kind of managerial side. I've always been bedside, so I don't really know the answer to how to make everyone happy to get the safe staffing ratios, but to also do it in a way where it's one financially, like you were talking about, there is a budget. You can't just hire unlimited nurses, and to do it in a way where you're going to actually retain staff and not have people leaving to go somewhere where they're not going to get mandated in on a weekend on their day off. I don't know the answer to that.
Well, and I don't know if anybody has the answer, which is why, here's the problem, and we probably will have another episode on this because things get dealt with like they just got dealt with, which is it reaches crisis management stage. So there's a strike, and then there's negotiations, and nobody's happy about that. It's adversarial, and then they finally come to a conclusion. Contracts get signed behind closed doors. It's not really made public, and then whatever happens, happens. And the question is it just temporary? And is it really a comprehensive solution? The answer is probably no. Because, again, we already have the legislation out there since 2021. It just didn't get enforced. And, who knows whether this is really going to solve the problem comprehensively. It's probably not. So, actually, with that, let me just turn to you, Kareem.
Sure.
You've had experience with the union. Give us a union side perspective on this.
Yeah, it's interesting because everyone gives the unions like a bad name, right? Like the union, they're terrible, they're this. But to be honest with you, that's your right as a citizen, is to organize, right? They're not organizing only, they think that the union only wants to be on behalf of the workers, but it's also for the patients. Because think about it, we're all patients at one point in time. All of our family members are patients at one point in time. And so you want to make sure the union is advocating for not only the compensation of the worker, but for that the environment is safe, that the practice is safe, right? Because if you think about it from a hospital standpoint, like if we want to talk about like margins and stuff like that, what's the biggest danger to the margins is malpractice, right? And malpractice, it goes up exponentially when the staff is burnt out and can't function correctly, like that's when the malpractice, that's when the mistakes happen.
Yeah, or
right?
longer hospital stays.
Totally,
right? I mean, there's
totally.
an argument that, hey, we get things done right.
So I think that at least what I've seen in the unions, they're not advocating for the wrong thing. They're advocating for the right thing, in my opinion. I think that a lot of them want the care environment to be the best that it can be. They typically have had a very long relationship with these hospitals. They have a good working relationship with each other. I don't know what happened this time around where things broke down. I think there's a lot of environmental factors on the outside, economic factors that don't help the situation. The fact is that these guys were asking for a very large increase in pay related to cost of living. And the reality is reimbursement for services doesn't go up for cost of living, right? So the reimbursement for the services is where it is. The cost of living is up here. How do you balance that? So I think from the union side, they're advocating for the right thing, in my opinion.
Now, the union is what? So New York State Nursing?
Yeah, this one was NYSNA.
NYSNA,
Don't
right?
quote me on what NYSNA stands for, but there
New
are
York
a couple
State
of
Nursing Association, and then 1199, right?
There's 1199.
And
I
what
think
else?
1199 was also around the same time in negotiations, but they somehow were able to settle that. It was NYSNA that really couldn't come to that agreement.
And we should point out, we mentioned it before, it was 3 hospitals. Northwell, who sponsors us,
And they
as a
happen to
matter
be
of
in the
full
city,
disclosure.
And again, in the city, you're dealing with a much higher cost of living.
Northwell has Lennox and stuff, but those nurses didn't strike. Kudos.
That is true. That is true.
For however they worked that out. My point being, there's variability. And again, the different health systems are faced with different challenges financially and otherwise. We don't know all the nitty-gritty in terms of that, but there's variability, right? So like NYU didn't strike. Catholic Health didn't strike. Northwell, which is, how many hospitals are they up to? 20, what are they up to now? 26, 7, right?
But what I will say is that practice environment is, as you said, it's different. It's kind of hard to quantify that. When I'm thinking of Northwell, a lot of the hospitals are actually spread out on Long Island. A lot of they offer different, not every hospital offers the same services. People just think I'm just going to go to the hospital. It's not every hospital is a center for this or for that, right?
Yeah.
There's a center of cardiac excellence, of neuroscience excellence.
Yeah, it's like North Shore, right? It's
exactly.
Doing
so
cardiac transplant for the whole system.
So I don't know how those other health systems are managed, but it seems like Northwell does a good job of having each hospital do its own thing.
Well, that's great because they sponsor us here.
So I feel like when it comes to that sort of thing, Northwell might have a little bit of deeper pockets to, make the staff a little bit more happy.
All right. On that note, that's a high note to end on. This has been really interesting. We're going to definitely circle back. It's a hot topic, and we certainly don't have all the answers. Maybe nobody does, and I don't think the strike's going to be the end of the story. So on behalf of my co-host, Kareem Nagdala, thanks always to John Mullen, our wonderful station manager. I just want to thank again our 2 wonderful guests, graduate students at the Hofstra Northwell School of Nursing and Physician Assistant Studies. That's Jess Keenan and Aaron Mandel. Thank you, guys.
Yeah, thanks for having us.
Thank you for having us.
It wasn't
very
too
fun.
traumatic.
It was a lot of fun.
No, it was fun.
I was a little nervous coming on here. I feel like
You did fine.
a little slow. Yeah.
And thank you all out there in our listening audience for tuning in once again to another episode of Nurse to Health. Stay well until next time.